This looks like a pre-first season spay, as she is young and has a small vulva. So the incision was made some distance from the umbilicus. The umbilicus is marked by the blue cranial dot. The fat is removed, so the linea alba is clearer, and so the fat doesn't get caught in the ovarian clamp. Using 2 pairs of forceps helps. Grasp the linea alba, and then pull up as high as possible to keep the stab incision safe. Keep the scalpel handle parallel to the body. Then extend with scissors while the muscle is raised, and keep the scissors parallel to the body. Sometimes there is a thin membrane. You have to break through this with your finger. Slide down the body wall, keeping the abdominal contents behind your finger. The area cranial to the bladder is usually best, as often just the colon present. Slide down to the vertebra and then slide up with your index finger hooked. It takes time to get the knack of it. Intestine feels more flattened, the uterus more tubular. If unsure, locate a bifurcation or an ovary. So I push down on the body wall to grasp the ovary with my left hand. I then transferred it to my right hand. Keeping tension on, I slide my left index finger down the suspensory and push down at the insertion. Do not break the renal ligament, only the suspensory. Note the uterus is easier to break than the ovaries, as the ligaments are protecting the ovary and hence the vessels. With the broad ligament window, keep the uterine vessel with the uterus. Make the window low down, through a transparent area, so you know it's safe. Now place the ovarian pedicle clamp. Do not force it down, but walk it down little by little, checking nothing is caught in it, and then clamp when a good distance past the ovary. We now separate the uterus for better accessibility and exposure. Place 2 clamps behind the ovary and cut. The swab is used to prevent mesenteric fat getting caught in the ligations. Now form the millers below the clamp. Nudge down so it's away from the clamp. Rotate the ovarian pedicle clamp and tighten the millers. Usually follow with 5 to 6 ones. Cut the tail short. Otherwise they get caught in the second millers. To note with ovarian ligations, always go full force. Do not hold back if cutting through the fat. This is actually a good sign of tightness. Release the clamps and raise the ovarian clamp. Palpate the ovary so you are sure you are still clearing it. Form your second millers, nudge down and then tighten. Make sure you rotate the clamp before tightening the ligature, unless you have accidentally broken the renal ligament, and if so, rotation may be too risky, as nothing is protecting the vessels. Now we can check for bleeding in a very safe situation. Remove all ovarian clamps and hold the bursa if needed. Check no bleeding if any concerns ligate again. Then replace the clamp and cut off the ovary flush with a blade. As this is a pre-season uterus, we will not be able to exteriorize. As much as we would like to, removing some of the broad ligament will help with exposure. Make a hole in the broad, low down, in a transparent areas and ligate, keeping the uterine vessel with the uterus. As the broad ligament was membranous, I just tore it, rather than ligating it. The bifurcation is not visible, so we need to trace the uterus back into the body, feeling for the other side branching off. If it is not evident on the left side, I check on the right in case it is twisted. Once palpated, follow it a little cranial, then exteriorize. If impossible to feel, then swap sides and find the second side, exactly like you did the first. Now trace to ovary. Push down on body wall to get ovary in left hand. Transfer to right. Slide the index finger down to the insertion and press down. As this side is thicker, this technique doesn't always work. In this case, push upwards, or split twice with a lateral force. In a transparent area of the broad ligament, make a low window, keeping it away from the major ovarian vessels. Don't force, just place and walk down the uterine clamp. Keep some of the tension on the ovary, as long as the renal ligament is intact, removing anything coordinate before you fully clamp. In this case, we have cleared the ovary by at least 3 centimeters. Place 2 clamps and cut between to separate the uterus. Form the millers, nudge down, rotate the clamp, and ligate tightly, follow with 5 to 6 ones. Raise your clamp, making sure it is still clear of the ovary, and add the second millers. Remove other clamps and check for bleeding. Then, if happy, replace ovarian clamp and cut the ovary off. Flush to the clamp with a blade. The broad window clamps were placed, and as it was just membranous, it was torn rather than ligated. As this is a pre-first season, we cannot get to the bifurcation. Rather than making a massive incision, we remove what uterus is there. This is okay as long as the ovaries have been fully removed. We place a surgeon's first, as least likely to cut through the uterus, followed by a miller's. We repeat on the other side. I avoid uterine crush beds, as I feel the risks outweigh the benefits. I have had too many damaged uteruses when I used to use them. We leave the golden centimeter and cut away the uterus. Avoid leaving any crush beds on the uterine parts which are staying in the body. In other words, don't clamp and the cut behind the clamp. If there was a bleeder, all the blood would have pulled out. So when you go down with the swab, it doesn't matter which area you go down, as long as it's deep to the bottom. We now close the muscle with a simple continuous pattern, but for safety, place an Aberdeen halfway down, and then continue. Note here, I remove some of the fat. This is so I can easily distinguish between the muscle layer form the fat layer. This is the Aberdeen. I keep the loop and tighten the pattern by spreading my fingers. Then grasp the single piece, pulling it through the loop. This then becomes the new loop. I tend to place 6 to 8. Always finish an Aberdeen with a double pass, rather than one. We now place the continuous fat layer. First pass deep superficial on one side, then superficial deep the other side. We tie off and first pass is deep superficial. We then go back on ourselves and continue the pattern. At this point, we take a small bite of the muscle, which flattens the fat down, removing any dead space. Then we continuous fat to fat. And then once again make a small bite of the muscle to reduce the dead space. I finished with the surgeons, and to tighten the ligature, I spread the loop with my fingers. It is essential to bury intradermal knots, otherwise you will experience more wound break-ons. As the knot sits between the dog's skin, it physically prevents skin-to-skin healing. To hide this knot, the best approach is to pull the knot down flat. There is no space to do it caudally, so it will have to be done cranially. Take a subdermally grab in front of the knot and then pass the needle subdermally on the other side, coming out in the intradermal position. Now close the skin with a continuous intradermal skin pattern. This time I finished with an Aberdeen. I tighten the loop and then pass the suture through to form the new loop and so on. I prefer to do several, 6 to 9. Make sure each loop is tightened. It has recently been shown finishing the Aberdeen with a 2-pass at the end, rather than a 1-pass, significantly reduces the chances of the knot breaking down. With the skin, it is essential to pass the suture through the loop twice. This considerably reduces the chance of the Aberdeen breaking down. Also make sure the needle exits the skin some distance away from the wound. Again, the secret of knot burial is the easier the needle passes, the easier the knot will bury. Try to leave a slight hole at the end and then wiggle the needle through. Keep it as close to the knot as possible. If you have finished with Aberdeen, lift the skin over so the needle exits some distance away. Pull on the suture material, but mainly use the forceps to pull the skin over the knot. Please support the charity. Subscribe for free.